So, hi everyone, thank you very much. And I saw in the chat there's loads of people from the East Midlands loving that, and some duty HEMS teams on as well. We're loving that as well. So, I'm James. I'm a kind of paediatric anaesthetist. I'm a all-age anaesthetist with an interest in paediatrics, and I'm also a full-time HEMS fellow at the moment at the Air Ambulance Service in the Midlands. I've been a basics doctor for a few years, working for EMICS for East Midlands Ambulance Service, and as you've heard, I've founded this project called KidConfident. So what am I going to talk about tonight is about pre-hospital paediatrics, and we're going to talk about what's different in pre-hospital paediatric trauma versus adult trauma in pre-hospital environment. About training standards in pre-hospital paediatrics, but especially trauma and emergency care for paramedics and ambulance clinicians, and the future of paramedic-led pre-hospital paediatrics, and hopefully your role helping to shape it. So as I just sort of said, it's a bit of an advisory notice. I'm not a paediatrician. I'm just barely a paediatric specialist. I'm a general all-age anaesthetist and pre-hospital emergency care provider. But that means I have to manage really sick kids, and it's usually when they're too sick or too far away from hospital, paediatricians and paediatric specialists to manage them. And that's the same for all pre-hospital clinicians, as I'm sure you know. But I'm much luckier than a lot of the guys in green, because I've had loads more training about peds, all the way from medical school and up to advanced anaesthetic training. And I even managed to squeeze in a little bit of paediatric surgery along the way. My view of paediatric peds isn't unique, but some may find it controversial, especially any specialists who are in the audience. So please don't hurt me or say anything bad to my mum. And I'm from South London, so it's probably not my fault. So let's get going then. We're going to talk about the differences in pre-hospital trauma care between children and adults. Kids are unfortunately most likely to suffer serious injury when they're most dependent on their parents, who are the most likely cause of that serious injury. So there's a psychological implication there for the crews managing that scene when they go to see that kid. The next most injured age group is 15-year-olds, and that accounts for about 11% of all paediatric trauma patients with an injury severity score over 15. So the peak age in under ones is 1 month old, which is just over 17% of trauma with that injury severity scale over 15 in under 1-year-olds. And the most common severe injury with an abbreviated injury scale of 3 or more is head injury. So abbreviated injury scale of 3, head injury always involves a brain injury. So it's pretty big stuff. There's transport differences, and there's the in terms of how kids get to hospital and which hospitals they go to, and you can see from this table that 50% of them will get to hospital in an ambulance, whereas 40% nearly will end up basically being taken by their parents. And that means that they don't always get to the children's trauma centres. They just usually end up in the local trauma unit. And that's very different to adults. And that changes the perspective of the clinicians in hospital who receive these children. And then there's a big exposure cap. Paediatric trauma accounts for about 5% of all pre-hospital trauma cases, so it's quite small money, and that means that the clinicians who go to paediatric traumas have less exposure dealing with it. So more practical differences, really. There's some environmental challenges getting to the kids in the first place. They can be at school or in other institutions, and they have security, so it takes longer to get in there. The location provided isn't always that accurate, so you don't know exactly what classroom, for example, in the school it might be. And bystanders getting in the way and being emotional and helpful, should we say. And that includes parents, carers, teachers, friends. There's always a lot of emotions with paediatric trauma cases. If there's an injured child, violence may be a cause for the injury, as we've just heard, but it may also get directed towards ambulance staff arriving on scene. most paediatric trauma deaths are avoidable, and there may be safeguarding clues, which the crews are also expected to pick up on when they arrive at a scene. So you can see there's quite a lot going on the environmental side for these crews to be managing when they go to one of these jobs. Then there's clinical challenges. A lot of this is to do with kit, the size, different size stuff, familiarity of different types of kit, and the availability of specific products which are designed for paediatric use. And things like child restraints for a trolley with a multiply injured child is quite challenging because spiders are designed for securing adults to scoops, not little kids to scoops or anything else. Communication with kids is different, and some find it more challenging than others. And then the clinical skills are always seen as being harder. Like it's harder to get a kiddie cannula than it is to do an adult one. And then you've got on top of that a load of maths with drug doses and weight calculations. And so there's quite a lot of thought that goes into treating these guys. And if it's only 5% of the trauma cases that you attend, that's quite a lot of your bandwidth taken up. But the single biggest challenge is none of that stuff. And it is so big, it causes clinicians to be paralyzed, doubt themselves, and that has a knock-on effect on their well-being and their ability to carry on and do their job the next day and the days after. I'll put my little advisory notes up here because it's the sort of thing that I get things thrown at me for saying this, but we've all heard children are not small adults and that we should all be very, very afraid of sick children. And that's a constant thing from all paediatricians everywhere you go. And this is the biggest challenge in pre-hospital paediatrics, because this is what paramedics and ambulance crews think paediatricians want them to think of when managing sick children. And they must do. You hear it so much. It's a huge, huge problem, and it's massive, and it shouldn't be, but it is. Now, I'm a strong believer in this as the message that should be told. And it's for important reasons that I'll tell you about. And when you take the guidelines and the evidence right down to basics, strip them down and have a real look, it's right. Children are actually a bit like small adults. There are some important differences, but we shouldn't really be scared of them. And this is the message that we should be given. And the thing that I keep with me and I say to others is that when it really goes south and you're dealing with trauma or resuscitation of children, you won't go far wrong by scaling adult care to size. And if all pre-hospital clinicians on tonight don't take anything else away from this, that's why I want you to remember this slide. So I need a lot of help to get this message through. So I've taken some advice from world leaders, influencers, and people who are always surrounded with praise for their diplomatic efforts and their policies influencing world peace. I've got these three, and they told me to wear a T-shirt. This is the T-shirt I wear, and this is what I say to paramedics. In the context of major trauma, children are small adults. I mean, why would I do such a thing? No, is it just because I'm antagonistic and I want to cause trouble? Or is there a real reason? Because the reason I say it is because at the moment, basics don't get done, not only in trauma, but in all areas of resuscitation. And I'm going to give you a real case from a couple of years ago. I got stood down from a 14-month-old cardiac arrest. I was 2 minutes from the scene. This is a basics job. The crew had left and they had a 6-minute drive to hospital. So I went to the hospital just to do a welfare check for the crew and a hot debrief, as I usually do when this sort of thing happens. And I waited there for them to arrive. Their journey time was 10 minutes from when I was stood down. And when I opened the doors, I heard, for the paperwork, the BM is unrecordable and JR Calc says it should be checked. that didn't fill me with joy, I must say. I mean, you can imagine the happiness of the receiving console in ED. And she gave me a really cutting glare, probably thinking I'd been on scene. And I said that I know and I'm going to deal with it. And I will tell you all how I dealt with it in a minute. We had a hot debrief, and somehow I managed to remain professional and contain my rage. And the senior paramedic actually thought they'd done okay, along with the student paramedic who was on board. And interestingly, though, the technician and the ECA were not so smiley. The senior paramedic told me that airway, we banged in an IGL ventilator on 100% oxygen using a paediatric BVM. Circulation, we had the pads on initially, it was PEA, and then deteriorate to asystole. Tried for cannula a few times, so couldn't get one, so we just put an IO, gave some adrenaline with a 20 ml flush. The temperature was 35.6 degrees when we got there, and basically we did that stuff and we scooped and run, doing CPR on the back of the ambulance, and gave another dose of adrenaline on the way in. He said that he thought that the patient, the 14-month-old, needed to be in hospital with a paediatric team, but realistically, he never thought the child was going to make it. And if you haven't tried before, and I'm sure loads of you have, including me, you can't really give good CPR in a moving ambulance, can you? Whatever delusions people have, it is rubbish quality, and there's studies and everything to show that. I asked about the glucose and got told that they weren't sure if it applied in children this age without them being diabetic. So they needed to check how to measure it in children, if it's the same like a capillary blood glucose, because they've seen it measured from the flashback blood in cannulas. So they weren't sure if it needed to be venous, and because they had an IO, they didn't have a cannula with a flashback and all that stuff. I think they were quite confused, right? And there's a layer of fear there too, because they don't want to do the wrong thing, so don't do anything. And then when you've not done anything, you feel uncomfortable, panic, and run, even though you know that there's backup 2 minutes away. I'm going to come back to the story about that in a minute, because that is not an isolated incident, and that sort of thing leads to this. This is the result of that management across the country. The most tangible difference between adults and kids trauma care, the mortality figures are at best static or likely worsening. This is data from TARN. ISS is the injury severity scale. 15 is equivalent to pretty mashed up, and so this is properly major trauma. And sadly, kids are most likely to die, as we said, from trauma under 1 year of age because of non-accidental injury. So that's a challenging scene. And then the 15 to 17-year-olds are the next most likely to die, have severe injuries, and that's because of motor vehicle accidents. If you want to know more about that sort of stuff, last month's webinar by Vicky Sleep from the National Child Mortality Database goes into this in much more detail, so I'm not going to go over that again. And there is a recording of that on the Trauma Care YouTube channel, and I can recommend watching it if you're interested in statistics and things like that, like this. But from this data shown here, 2019-2020 had the lowest number of severely injured children in the 5-year period from 2015 to 2020, but it had the most deaths and therefore the highest percentage mortality. Some of that is probably due to the pressures of COVID in 2020, but not all of it, because that might have also contributed to the lower number of injured children. And it was only the last third of this 2-year period that was really affected. But even leaving that alone, there's no real improvement in mortality like we see in adults who have a kind of similar mortality. It's worse, but not much worse. And there's a paper that shows between 2008 and 2017, when they were comparing looking at the introduction of major trauma centres and the effect it had, it showed that 9.2% of adults with an injury severity score over 9, so not quite as badly injured, but over 9, and it includes obviously over 15s, died. So it's 9.2%, and that's compared to 8.5% of children, or between 7 and 8.5% of children. That includes elderly, frail patients, complicated medical background, deconditioned lunatics that do all sorts of dangerous activities, and the majority are old, as we know, and have some degree of frailty. And I might be wrong, but I would expect a larger percentage difference in trauma mortality between that group and the group that are physiologically programmed to repair and grow and have physiological resilience without years of self-abuse through smoking and alcohol. So doner kebabs complicating matters. So what's my inflammatory t-shirt got to do with this? Training. That's what it's got to do with it. As we saw from my previous slide, 11% of paediatric trauma gets a trained doctor pre-hospitally. All IBT FEM curriculum trains doctors in pre-hospital medicine, and all the doctors that are eligible for this training are from specialties that have specific paediatric training modules and requirements. So doctors' paediatric FEM training is actually quite good. But what about paramedics and other clinicians? These are the bodies responsible for clinical standards of paramedics. They set the curriculum, the requirements for ongoing CPD, guidelines, and they protect the public. And here are their paediatric training standards for paramedics. And that's it. This is the standards that exist for training in paediatrics for all ambulance clinicians. And it doesn't mean there's no training, but there's definitely no standard. And that's unsafe. The training received, the capabilities and the confidence of the paramedics treating children is massively variable between services and individuals. And we saw before how exposure to major trauma in children is low compared with adults. Around a quarter of the cases and just over half of these call an ambulance. And it makes up 5% of the total workload. There's 2,100 cases of paediatric major trauma receiving pre-hospital interventional care per year in the whole of England and Wales. There are around 58,000 paramedics in the UK, I think. So with paediatrics only accounting for around 5% of the total ambulance workload, there's really limited opportunity for exposure and experiential learning, unlike in adults. So HSIB, which is the Healthcare Safety Investigation Branch, they investigate deaths of pregnant women and children. And they did an investigation about a death of a child who actually had meningitis, nothing to do with trauma. But on the back of that, they made these recommendations, which I think are quite clear and simple. They said that we should be sharing paediatric education resources between ambulance services and developing some standards for training. And in their mandated responses, the AACE, the Association of Ambulance Chief Executives, said that they would set some statutory requirements for paediatric education in ambulance trusts by the end of March 2022. The College of Paramedics said that their curriculum was under review and the new version would be published in January 2023. And it would have a dedicated paediatric curriculum for undergraduate training. So there would also be some e-learning, spotting the sick child would feature, and access to an online handbook to help diagnose skin lesions in non-white children. And this all sounds quite good. In July 22, AACE, the chief executives, they delivered. It was 4 months late and they got their juniors to do it, but it was done. So they're obviously taking it seriously. And they basically said, make everyone do spotting the sick child. What a waste of effort. I mean, there's that bit about paediatric resus education being delivered annually as part of statutory face-to-face education. That's probably made things worse, as I'll explain in a minute. I mean, to be honest, my mum could have done a better job, and she's a retired piano teacher. But because spotting the sick child, which I'm sure you've all done, starts with that bit that says, if you identify a B problem, you must call 999, which is really helpful when you're the 999 responder. And then it goes off about drugs, percentiles, growth, blood, and all sorts of stuff that none of us care about or need to know anything about. And the statutory training, the annual face-to-face training, the problem with that is it feels like this. It's taken as a test, isn't it? It's not an educational opportunity. And in some places, that's exactly what it is. If you fail, then you're off the road for a period of retraining. All your mates are going to know that, and you're going to be the one that's bad at peds. You'll have to go back to the station after you've done your retraining with everyone thinking that you're an idiot after you passed. And that's the feeling that people get. That's what I'm told anyway. And it also correlates with staff sickness too, apparently, when they have to go to face-to-face training. It's not a learning opportunity if that's the case. So we're holding out for the college curriculum. Now, why didn't that work? There we go. So in October 22, I went to this conference, which you might have heard of these people before, Trauma Care, in Yarnfield. And this guy, Will Borton, gave a talk. And he did more or less the same sort of talk about training standards, and said more or less the same things that I've just told you. Now, he is the course leader for paramedicine at Buckinghamshire University. He's a senior lecturer, researcher, and he's an established paramedic with a fellowship award from the college. So there's no messing. He said that he'd been tasked with the paediatric curriculum for the college and that it wasn't really gaining much interest. So it had been really slow progress. It's no good, is it? And so I got interested, and so did a group of actual experts. And in March last year, which is 2 months after the deadline of publication, a paediatric curriculum for paramedics started to be developed under Will's guidance and direction. So the group that Will put together took these 3 curricula and mashed them into one. Interesting, St John's Ambulance have a paediatric curriculum for their clinicians. We removed some duplicate topics and then used a panel of experts to decide what needs to be in a curriculum for paramedics. A modified Delphi study technique was used, and the results were used as the basis for group discussions in a meeting in Birmingham last May. And basically, essential topics made it in, not needed topics were binned or discussed, and nice to have topics were discussed. Some made it in, some didn't. And there was over 1,000 topics that were went through this. Anything discussed had one of 3 outcomes. It got in, it got binned, or it's been set aside for an advanced role such as CCPs or specialist paramedics for development. The data has all been collected, sorted and discussed and crafted into a draft paediatric curriculum for undergraduate paramedics that looks a bit like this. So Prof. Borton got this, and it's very exciting. I was very excited. And he's presented it to the College of Paramedics at the end of last year, and he got some feedback. This was the feedback. They want 5 learning outcomes for the whole of pre-hospital paediatric care. That is going to be a challenge, and it doesn't really reflect the draft curriculum that was put together by people who know what they're talking about. So now what? Because I personally don't think that 5 learning outcomes is enough, but that hasn't put any of us off trying, and the group, under Will's direction and guidance, is trying to develop a workable solution that will keep the college happy and will actually be meaningful in terms of improving paediatric outcomes and paramedic wellbeing. If there is anyone from the college here, please don't beat me up for saying these things. So that's all good. That's for undergraduate training. But what about the 58,000 paramedics that are already out there? Do you remember that story of the rest I was stood down from that I started going on about before? So I said that after receiving a cutting glare from the ED consultant and telling them that I was going to deal with it, that I would tell you what I did and how I dealt with it. Because I had some choices, but I did feel that I had to do something because there was no choice there. I have professional obligations as a doctor. Option one is to fill in a DATIX or an incident form, inform the operations manager that I was unhappy with the clinical care that was given and that there was a patient safety issue and all that stuff. And the whole crew would be taken off duty, receive some retraining, go back on duty, filled with resentment and probably more fear of sick children. It ticks the boxes, take a hour max of effort probably, and it's the right thing to do according to some people, but this isn't the first time I've seen something like that. And the whole panic and run thing with kids, it's just what people do and what some people think that they should do and they still do, and they'll carry on doing if nothing changes, because they haven't been told otherwise. So sure, there's like a keen few people, probably like all you guys who have joined this webinar tonight, who will read up and make the effort to close their knowledge gap, and you can spot them, to be fair, a mile off. And when I do arrive on scene for one of those jobs, I know it means that there's hard as nails kick-ass paramedic calling the shots on scene, and I'm right 100% of the time with that. So we need more of that, not taking otherwise really good crews off the road and beating them with education, because remember what mandatory ambulance service delivered education feels like? So I spoke to the medical directors at my ambulance service, which is EMAS. I'm sure they don't mind me saying that. And I spoke to them quite a lot and gave them a headache. And I defended myself for not following procedure by filling incident reports and all that rubbish, but highlighting it as a wider issue, as I thought that that's more beneficial to everyone because then they can act on that. And luckily for me, probably they know me quite well after 8 years of me being an EMICS doctor, basics doctor, and managing the equipment for the time too. And I have got a gob, and they've heard it. So they let me do a little education project for 3 stations in Derby City, which is where I'm based. So that's Mickleover, Willow, and Wainsway. And I could probably even use it towards my peds anaesthetic training too. So that's, win-win. So this is what I did instead of an incident form. This is KidConfident.org. It's free. It's open access paediatric medical education for UK paramedics and pre-hospital clinicians. The only paediatric FOMED site for paramedics in the UK, specifically for paramedics in the UK. It's based on learner-directed learning. So the content is what people want, not what I or anyone else thinks that they should be told-ish, and has a content editorial site for people to submit content to that gets peer-reviewed and then it's published online. This is based on a system that proper journals use to run their content submission stuff. So within a fortnight of this starting, there were about 50 new visitors a week to the website for one poster. Topics were requested, and the top 2 most popular topics were sepsis and childhood cancer. In fact, most of the top 6 topic requests included subjects related to these areas. I was either surprised or I was surprised. I was surprised, and I thought it was either surprising or it was a coordinated piss take, which I wouldn't put past a lot of people. But those visitors weren't all from these 3 stations that I put the first posters in. So what's Google up to? Turns out that lots of ambulance clinicians want to learn more about paediatrics. So I put some learning resources up specifically for paramedics in the UK, put together some clinical tools using trials of various design softwares, and did some posters about sepsis. And people are signing up to provide content from universities and services all over the UK. And then Melissa Mead from the UK Sepsis Trust got in contact and helped me by providing some more tools and resources. And she even reviewed the poster for us. It was awesome. And then CPD got hold of me and told me that they needed to help me with a plan to fund this because very soon it was going to drain me, and they were right. So this week it is now a year old. The team is 4 people now, just from me, and we've got a 5th person who's going to be joining us soon. We've got a YouTube channel which has got that CPD Me original webinar, and we've got some more planned, like today's one. And we've got some other things planned with other things like this. And EMAS are using us for their paediatric CPD. All they have to do is distribute posters, and it's otherwise completely free for them because sadly money is the obstacle to rolling out paediatric training. Other services do seem interested, but £145 a year per station for packing and delivery costs is still too much, unfortunately. So maybe I should put an AI bot on the site and get 21 million or something off the government instead. But we're getting around 300 unique visitors a week, and I think actually in the last couple of weeks we've had nearly 1,000, and that's because we put out a new poster and it goes up whenever a new poster is published. We've got a growing social media following, and that just shows that paramedics want to learn more about paediatrics, and this is what's available to them. So how's it work? So there's contactless technology, so it can be done in stealth mode. That's a bit of a gimmick, but who cares? And this option 2 has taken significantly more effort than filling in an incident report form would have done, and it's cost me more money. But luckily, I've had some good support from the public. There was a crowdfunding campaign, and Schiller UK, who I'm sure you've all heard of now, also gave me some cash to fund it. But basically, using the contactless displays, clinicians can use physical posters in ambulance stations to make their phone go to a page on the website where they can request learning topics, and the most favorite learning topics get turned into posters, or the themes get turned into posters, and it gets rolled out. It's meant to be every couple of weeks, but it's not quite as efficient as that. Sorry. And this is my plan for improving on 5 learning outcomes for paediatric training for paramedics. And this is definitely taking some effort, and it will take some more time to finish, but the curriculum that a group of experts think paramedics should be taught will be available through KidConfident in the next couple of few months or something, with certificates and everything. And there's also some collaborations in the pipeline between KidConfident and the American College of Surgeons with the catastrophic hemorrhage training. Teach Me Paediatrics want to put a question bank together for paramedics about PEDS. The Paediatric Blast Injury Group have been massive supporters, and we're involved in their pre-hospital paediatric trauma course that will be freely available. And there's a analgesia for injured children manual, which is also in the pipeline with the World Innovation Summit help. That's through the PEDS Blast Injury Group. So that's all good, isn't it? I'm struggling to do all of this on my own. So I need you guys who've signed on tonight and are keen to help me make a difference. Because if you're an ambulance clinician and have a question about paediatrics, others probably want to know those answers to those questions too. So we very recently set up a Facebook group, which is an online version of the Ask Me contactless points on the poster displays in the stations, and that is available to everyone. You can use this QR code to access it. All I ask is that you fill in the entry questions, otherwise the bot will decline you and send you a little message. That will help us build up a list of topics that people want to learn about across a wider area than just East Midlands. We have a group of experts, including some paediatricians, ACPs and CCPs with an interest and experience with PEDS in the group, and everyone there is ready to answer questions and help reduce the fear surrounding sick children. It's a safe place that people can ask questions, or you can send by a direct message, and it'll get answered on the group. So everyone gets the answer, but you don't even have to show that you are the one who's asked. And as I said, all I ask is that you answer the membership questions and agree to the group rules when you join. So that's one way you can help me make a difference. But this isn't all ambulance clinicians and paramedics in this group. So if you are a hospital clinician or a specialist and you want to beat me for saying that children are small adults, then why don't you show me better and help me and get involved in creating some educational content? This QR code will take you to another page on the website, and this is not publicly available without the QR code, or you can get to it again, but you need the QR code to find it. And if you've got a burning topic that you think that paramedics should learn about, and would like to impart your knowledge and help me with posters or webinars or infographics or e-tutorial for the curriculum site, then please scan this code, fill in the form, and I'll definitely get you to help me. The only thing I ask is don't say viral wheezes and asthma and not giving salbutamol to little kids, because that's last time I did this is what everyone said. So that's been covered, but anything else. And that's it. Thank you very, very much for listening. I'm just going to leave that up as a reminder, because in the context of major trauma, children are small adults, and I would love you to all remember that and be kid confident. Join our Facebook group and get involved with the website, and send me all your suggestions on how I can make it better and more appropriate to you, and help you be more confident. If you're a hospital clinician, please remember all of the lack of structured training for ambulance clinicians and paramedics. So the next time that they bring a child to you in ED, just remember that the scene they've been to, the environment they've had to deal with, and notice what they managed to achieve without any specific pediatric training, because I think you'll agree, now that you know these things, that actually when they bring a child to you out of that sort of scene, they've done a spectacular job and they're proper legends. So respect that and remember it. And that's it. Thank you very much. There's some questions and answers, hopefully, and I'm going to hand back to Anna to be in charge of all that.
Wow, I just want to clap. I don't really have any. I just want to sit here and clap for that, really. I'm just popping a message into the chat as well, because there's lots of people sort of saying, someone's asked for the t-shirt and someone else has asked for a QR code to go up and all sorts, and how do you apply and all sorts, and apparently we've crashed the website as well because I was also on it. So I'm just going to pop this link in, guys. For the Kid Confident course, go to, and if you follow that link, because I've just found it as well, if you go to that link, you will be able to order your children and small adults t-shirts from the Kid Confident shop, which I'm going to wear, and I'm going to wear it around the Trauma Care conference, but I don't have to wear my official Trauma Care t-shirt because I love a joke t-shirt and we've got our own, so why not add to the collection? And it's not a joke, it is true. Kids are small adults. So